Our next presenter is Dr. Lopez-Acevedo from the Lankenau Medical Center, talking today about major elective laparoscopic colorectal resections, whether these can be performed in 80 to 90-year-old patients with low mortality at 1 year, their experience with 179 patients.
Thank you for allowing me to present our data in major colorectal laparoscopic surgeries in patients aged 80 and above with a low mortality rate and experience of 179 patients. We don't have any conflicts of interest. As a result of improvement in surgical technique, anesthesia, and increase in life expectancy, there's a growing elderly population requiring surgery. Age is an important risk factor for colorectal cancer, and people aged 80 to 84 have 7 times the risk of developing colorectal cancer than those aged 50 to 54. And within the next several decades, individuals over 85-year-old will triple. So why are surgeons still reluctant on performing laparoscopic surgery in the elderly? It is due to concerns in higher complication rate, longer operative times. And how many times have we heard this? We have to be mindful, looking at this data, that the expected 1-year mortality rate for the general population of 84 years in the United States, it's 8%. And while there's numerous randomized trials showing the short-term benefits after laparoscopic colectomy in younger population, there is limited data on outcomes in patients 80 years and older. So our purpose was not only to evaluate the 30-day mortality rate that's usually reported, but also the 60-day, 90 days, 6-month, and 1-year mortality rate following surgery, as well as to look at their cause of death. From a prospectively maintained database containing 1,768 laparoscopic procedures, we identify all patients aged 80 and above who underwent a major laparoscopic colorectal resection for a total of 179 patients, which formed the basis of our study. All surgeries were performed by the same surgeon. Not surprisingly, the most common diagnosis was cancer, and as listed, procedures range from right colectomies to pelvic TME. Here are the demographics. Mean age was 84 years old, and 18 patients were older than 90 years old. Also, greater than half of the patients had previous abdominal surgery. Following surgery, around 93% of the patients were able to avoid the ICU. The mean days to discharge was 5, and as you can see, 72% of the patients were able to be discharged home. The standard 30-day mortality rate was 0.6%, and the overall morbidity rate was 29%, with two patients having a leak with an asymptomatic leak rate of 1.1%. In looking at this mortality rate closer, the 30-day mortality rate was 0.6%, and the 1-year overall mortality rate was 9.8%. Of note, patients 90 years and older did very well. None of them died within the first 30 days, and the mortality rate at 1 year for this group was 6.2%. Furthermore, 62% of the deaths were non-surgery related. So what factors correlate with the mortality? No factors impact the 30-day mortality rate, and not surprisingly, higher mortality rate was found in cases that were extended, cases that had increased blood loss, and pelvic surgery, which are all markers of more complex surgery. So how do we do? It is well known that older patients require more often post-operative intensive care. However, from our 179 80-plus-year-olds, only 7.3% went to the ICU, and 72% were discharged home, And in order to do this, they weren't kept in the hospital for a long time. Indeed, the mean length of stay was only 5 days. The standard perioperative reported 30-day mortality rate was only 0.6%, which is well below the expected mortality rate following major laparoscopic surgery. And the 1-year mortality rate was essentially the same as a general octogenarian population. We conclude that major laparoscopic colorectal resections can be performed with a low mortality, and the key to our opinion is that the key to this is that they were able to recover fast and also to maintain their independence following these laparoscopic approaches. For this reason, age should not be used as a reason to withhold laparoscopic colorectal surgery. In fact, this age population of 80-plus-year-olds may be the most to gain from a laparoscopic approach. Therefore, this option should always be discussed as a possibility with the patient. Thank you.
So, questions? Anybody from the audience? Because I'll ask a couple. Here we go. So here from the audience, thank you. Hold on a sec. Did any of the patients with rectosigmoid strictures growth with obstruction, which is common, presented in this group? So what about acute surgeries? Were these all elective cases?
They were all elective cases, yes.
Okay. And then do you have any comparison with the younger population? Any sense of how this group does compare to those that are younger?
Well, specifically, we just wanted to look at the mortality at 80 years old, so we did not compare this group population to a younger one.
The interesting question would be is, if you get to 80, are you protective against early mortality compared to somebody who's 60 to 70? In other words, if you look... Go ahead.
We're not, and that's why I think this study is important, and as we know, there's 80 years old and there's 80 years old, but we think overall they're able to tolerate surgery well, so we're not protective, and that's why we want to show the study.
Question. Can we get the microphone in the front?
Hello.
Go ahead. Yes, perfect.
Yeah. Excellent presentation. I come from India. In our country, we get a lot of patients with a progressive constipation. And when they come to us, most of the time, there is a stricturous growth at the rectosigmoid. They come with obstruction. So these are the patients, post-op histopathology are well-differentiated lesions, and the lymph nodes are very few involved. And they, without adjuvant treatment in the post-op setting, they do extremely well. Probably the screening, irrespective of the age, and early detection of this constipation is an important factor, which gives a better results of the thing.
Thank you. Anything else?
Sure. How do you, or do you know how these patients were chosen for surgery? Meaning, what determined the 80 or 90-year-old to be fit enough to have an operation for this? Because clearly, in all age groups, there are people that aren't necessarily deemed fit enough to have
definitely.
surgery.
So all these patients had a cardiac pre-op evaluation. I didn't show, but basically, 95% of these patients were ASA 2 and 3. We didn't have any 4. There was no emergencies. But so basically, the whole group was between 2 and 3 ASA.
But I guess the question in this group, and somebody asked this, is there additional things other than looking at ASA score in an older population, or the performance scores, what their home skills are? Do these patients go to a geriatric person for an evaluation to determine if they're frail, fit, or vulnerable? Do you know?
No, they do not. Usually they just go, most common things going through a cardiac pre-op. Right. But they do not go through geriatric doctors.
And you may not know the answer, but John may. Are there patients who were turned down for laparoscopy because of their comorbidities? In other words, this group is already pre-selected. I kind of know the answer, John, but I think we want to know, were patients excluded and then had to have open because of the risk of laparoscopy?
No, and that hasn't been my experience with them.
And I think most of us would agree with that we can usually get a patient through that type of procedure, at this stage. The one thing I'll ask you to think about is that your mortality at 60 days started to click up. And were any of those deaths at the 30 to 60 day related to the procedure that we may have missed in that first 30 days?
So that's a good point, but we have to keep in mind that even at 60 days, which I think it was about 3.7%, that's still lower than the usual mortality rate reported for younger patients after major colorectal surgeries at 30 days. So it's still a lower one. And for this study, for example, if a patient had a pneumonia 6 months after surgery, we still categorize that death as surgery related. So.
Okay. And I agree, you know, you have to sort of decide what is and what isn't surgery related. All I will say is when you do the manuscript, the older population over 90 had a 5.6% mortality at 60 days. So make sure you define well what the causes were, not just the 30, but the 60. Because I consider that still in the early post-op period. But the message is, what's the message?
Let's do laparoscopic surgery to everyone.
All right, that we can do it now probably safely in an older population. Thanks very much.